Hey bootcampers, welcome back to another video. This is David, your guide to gastroenterology, and today we're going to be covering drug-induced hepatic pathology. And we're going to start off by talking about Reye's syndrome. You may already know of Reye's syndrome. It's a childhood hepatic non-inflammatory encephalopathy. And this syndrome is particularly notorious for having a high mortality rate. To understand Reye's syndrome, we first need to understand what this vignette is going to look like. So Reye's syndrome occurs as a result of a child being treated with aspirin, and classically this is following viral illness. Two of the most common of these are going to be varicella and influenza, and the treatment with aspirin is what actually causes our problems here. Now I do want to note here that while treating children with viral illnesses such as varicella and influenza with aspirin is inappropriate, Kawasaki disease should be treated with aspirin, and is the exception to the rule when it comes to not treating children with aspirin. Now the pathophysiology here, as I mentioned, is caused by these aspirin metabolites. Essentially, the metabolites of aspirin cause a reversible inhibition of our mitochondrial enzymes, and that is going to lead to a decrease in beta oxidation as well as a decrease in our oxidative phosphorylation. What this is going to result in is a decrease in overall mitochondrial activity, and that is going to cause an accumulation of ammonia, which is what is going to lead to our encephalopathy. As I just mentioned, our vignette is going to be a child mid or post-viral illness being treated with aspirin, and what's going to happen to this child in addition to that encephalopathy is that they're going to have microvesicular fatty changes on biopsy of their liver. They're also going to have mitochondrial abnormalities, but it's this microvesicular fatty change that I really want you to pay attention to here. The vast majority of the time we're talking about a liver biopsy, we're going to be talking about macrovesicular change. You may remember this from our discussion about alcoholic hepatitis, as well as viral hepatitis. Pretty much any other form of hepatitis except for Reye's syndrome is going to be discussing macrovesicular fatty changes, while Reye's syndrome is going to present with microvesicular fatty changes. And you can see an example of these microvesicular fatty changes right here on histology. So in our macrovesicular fatty changes, we had these significant ballooning hepatocytes, and you can see here that this looks very different from the fatty changes that we had during our alcoholic hepatitis. But that being said, this is a fairly tough thing to identify on histology without a trained eye, and so what they're really going to give you is the word microvesicular. If they give you that word on a liver biopsy, you should immediately start thinking about Reye's syndrome, especially if the vignette of a child who had just had a viral illness and took aspirin pops up. Now that child, when they come in, is going to have the following symptoms. They're going to be vomiting, they may have hepatomegaly, they're likely going to have hypoglycemia, and of course they're going to have encephalopathy leading to coma. That encephalopathy is going to present in children with a worsening mood, confusion, lethargy, things like that. Instead of describing a notable personality change, they may just describe a child's irritability or confusion. But either way, this child is not going to be doing well, and in your vignette, you're almost certainly going to be given a discussion about aspirin and some form of viral illness that the child just recovered from. The next drug-induced hepatic pathology we're going to talk about is acetaminophen toxicity. And so we're graduating here from children into teens and adults. So in acetaminophen toxicity, we're going to have hepatic failure as well as necrosis due to an accumulation of toxic metabolites, and these are going to be toxic metabolites from acetaminophen. Specifically, our CYP450 enzymes are going to metabolize acetaminophen into something called N-acetyl p-benzoquinonamine. But instead of saying that mess of a word, we instead say NAPQI. And NAPQI is notably going to deplete glutathione, and that is going to result in a buildup of toxic metabolites. It's also worth noting here that alcoholism and alcohol use will activate your CYP450 system, thus increasing your chances of toxicity. Now this is going to happen because that CYP450 set of enzymes is going to increase the production of NAPQI, thus further depleting glutathione, which is why you may have heard people warn against taking acetaminophen while drunk or hungover. Now the presentation here is going to be important, not only for your step 1 examination, but also if you ever see this come up in real life, because the symptoms that we're going to be dealing with here are fairly non-specific to begin with, namely nausea, vomiting, and lethargy. These symptoms by themselves, without any other history, are going to be a very difficult thing to pull acetaminophen toxicity from. However, in the next 12 hours, you are going to see a dramatic rise in liver enzymes, and then within 48 to 72 hours, hepatitis is going to progress rapidly, leading to multi-organ failure and death. And once you've reached that 48 to 72 hour point, there's not a whole lot of ability to turn back the clock. And so let's look at the diagnosis and management so that you can catch this before it gets to that point. So one of the main things with our diagnosis is going to be drawing an acetaminophen level. Now, the important thing about that acetaminophen level is that it needs to be drawn following a 4-hour window of ingestion. So that means if our patient comes into the clinic and they took the acetaminophen 2 hours ago, we need to then wait another 2 hours in order to make sure that we are actually understanding how much acetaminophen they took. Additionally, let's say someone comes into the emergency room and they took an unknown amount of pills an unknown time ago. In that case, you're going to want to assume that it's been at least 4 hours, and you're going to want to test their acetaminophen levels, and then you're going to want to wait and retest their acetaminophen levels to see what has changed, because those acetaminophen levels could still be rising. Let's say, for example, someone has attempted to commit suicide and they've taken a whole bunch of different pills and they are unconscious, and you are not able to tell whether or not they have had acetaminophen in their system or not. You may, in that case, want to draw repeat levels of acetaminophen in order to make sure that you are getting it in that 4-hour window, because otherwise you're not going to be able to tell how much acetaminophen is in their system. Now, going back to that 4-hour window, if you are inside of that 4-hour window, for example, if a teenager comes in and says, I took a whole bunch of acetaminophen, I was trying to commit suicide, I now regret it. If you're within that 4-hour window, you want to give them activated charcoal. Activated charcoal is going to essentially soak up everything inside of their system, and as long as they're still within 4 hours of ingestion, that's going to be an excellent sponge in order to remove a bunch of acetaminophen from their system. Now, getting back into why it's important to catch this, even with these very generic, vague symptoms, if N-acetylcysteine is given within 24 hours of ingestion, in that case, you can replete glutathione. N-acetylcysteine not only repletes glutathione, which is then going to allow for NAPQI to be broken down again, but N-acetylcysteine also bonds to the NAPQI in order to prevent the toxic effects of this metabolite. So to go over this briefly once more, NAPQI is a toxic metabolite of acetaminophen. And normally NAPQI isn't something you particularly need to worry about after taking acetaminophen. However, too much NAPQI will deplete glutathione. And too much NAPQI depleting glutathione leads to this buildup of toxic metabolites, specifically our NAPQI. This is our toxic metabolite, and this NAPQI is going to react with and destroy our hepatocytes. And because of that, if we can give someone activated charcoal within 4 hours of ingestion of the acetaminophen, or if we can give someone N-acetylcysteine within 24 hours of ingestion, we can really help to save their life. Now, before we end this video, I want to cover 4 different drugs that have hepatotoxic effects. I cannot express enough how many drugs have hepatotoxic effects. The liver's job is to metabolize things. Drugs have toxic metabolites. The liver is going to be the source in which toxic metabolites are born and then destroyed. Of course, drugs are going to have hepatotoxic effects. When in doubt, you can almost flip a coin and have hepatotoxic or nephrotoxic effects come up as a drug side effect. However, there are some really notable drugs that I want to touch on right now that are going to stand out a little bit from the hepatotoxic crowd, or just be a good example of a drug that's hepatotoxic. Now, one of these is halothane. Halothane is an inhaled anesthetic, and halothane can lead to massive centrilobular hepatic necrosis. This is a very notably hepatotoxic drug, and this specific hepatotoxic description here, this massive centrilobular hepatic necrosis, is what you need to know about halothane, the inhaled anesthetic. Next up is amiodarone. Amiodarone, as we know, causes a bunch of different side effects. However, one of these is going to be hypersensitivity hepatitis, and this is going to require liver function tests being done in order to monitor how the patient is able to tolerate amiodarone and how their liver is doing. Similarly, azathioprine or 6-mercaptopurine can also cause hepatitis, or reactivate viral hepatitis. And similarly, you need to do LFT checks on somebody who's taking azathioprine or 6-mercaptopurine. And you also want to make sure that someone who's about to take this drug doesn't have dormant Hep B or Hep C. And then one final drug I want to touch on is macrolide antibiotics. Macrolide antibiotics, specifically azithromycin and erythromycin, can cause cholestatic hepatitis. It's a unique injury pattern that combines injury to the hepatocytes directly, lobular disarray, and also injury to zone 3 of the liver, which is going to be the cholestatic portion that we're talking about here, because zone 3 of the liver is going to be where our bile first gets collected as it heads towards zone 1 of the liver, which again is where our bile duct is going to take it and send it out to the biliary tree. So injury to zone 3 of the liver is going to essentially cause congestion of that bile, and it's unable to really reach zone 1. That is cholestatic hepatitis. I should also mention that another drug that we haven't put in this list that is notable for causing hepatotoxic side effects is isoniazid for the treatment of tuberculosis. It's definitely something that should pop in mind when you think about hepatotoxic drugs. That's it for this video. I hope you all enjoyed it, and I'll see you in the next one.